the side effect of sexual dysfunction. The treatment and how we address a loss of libido, dampened sexual desire, which can be total in certain patient populations, primarily postmenopausal women. In those cases, the most common thing is to add Wellbutrin or another dopaminergic agent to overcome what is essentially amounts to anhedonia. Serotonin calms things down, including sexual passion, and you're just not as excitable. You don't get upset as easily, you don't get worried as quickly or as much, and you don't dwell, and you don't get as angry, but you also lose passion in the bedroom. It goes with it. One of the recognized side effects of overly aggressive serotonergic pharmacotherapy is apathy. And you sort of lose your sense of urgency for everything, for going to the gym and for taking care of things. And so people will often report that they're not getting things done, they're procrastinating more, they have a lack of initiative, and that they don't enjoy those things that are pleasurable, just as they're not as harmed or put off or bothered by things that are stressful and that cause dysphoria. Many things can affect the libido, in particular hormones. So we do see a diminishment of the male libido, for example, in middle age and in later years due to declining levels of testosterone. Testosterone, which improves libido in men and women, but healthy men, even with a decline in their testosterone levels, typically have a very high sex drive, and it's very uncommon for a male patient to report a complete lack of sexual desire, whereas in postmenopausal women, it's a frequent complaint. And in fact, that's a phenomenon that is known to occur in postmenopausal women who are not taking any medication to make it worse. But the way to reverse that is to increase dopamine, because in the central nervous system, dopamine and serotonin oppose each other. They actually affect each other's levels, such that if you raise one, you dampen the other, and vice versa. And dopamine is the neurotransmitter, the principal neurotransmitter that's implicated in pleasure seeking, and whether it's from food or sex or other behaviors that lead to rewards, cocaine, things that feel good to the brain. The final common pathway is usually dopamine, and there are specific centers in the brain, nuclei, where there is a preponderance of dopaminergic synthesis and dopaminergic neurotransmission. So Wellbutrin is usually the first step. It's an antidepressant as well, and it's used for smoking cessation, but it blocks the reuptake of norepinephrine, adrenaline, and dopamine, and that dopaminergic component is what offsets the serotonin that is dampening the libido. Even more effective would be a medication like Adderall, which is an amphetamine. It blocks the reuptake of dopamine, but also causes the release of dopamine, and so it's much stronger in terms of its dopaminergic activity, milligram per milligram, than Wellbutrin. It also has its own set of problematic side effects, and so it's not always appropriate to use it. But of the medications that are currently on the market, it would be my opinion that medications like Adderall, and to perhaps a lesser extent, the various generic preparations of Ritalin, methylphenidate, those are the most effective at increasing libido. I usually start with Wellbutrin, however, because that works for a lot of patients, and it's got fewer side effects than the amphetamines and virtually no abuse potential. Unfortunately, this is another side effect that can be an indefinite, that could be essentially permanent while a person is taking that medication. But regardless of the agent and regardless of the dosage and regardless of the time that a person has been on a given agent, when they then come off of that medication, they return to their baseline, or if it's many years later, whatever their natural libido would be at that particular age, given the hormonal environment and also the other factors that include psychological stress and other medications and substances that directly affect the libido. Again, it's much more of a problem in women than in men, because even men who are in poor physical health and poor mental health often will exhibit a very active sex drive until death. I've treated many gentlemen, older gentlemen, who suffer from dementia and various very severe cognitive symptoms, have also behavioral symptoms, but they're still interested in sex and they're still sometimes seeking it. In fact, that's one of the problematic behaviors that we often have to address in older gentlemen with advanced dementia. The inappropriate behavior, the disinhibited, socially inappropriate behavior includes sexual aggression or sexual impropriety. And it's just a reflection, an indication that you could be very old and not in good health, both in terms of your general overall health as well as the health of your central nervous system, and still have an intact libido, a libido that's strong enough where it leads to behavior that is often problematic. And many couples that have been married for a long time also have to often negotiate the phenomenon that after a woman completes menopause and is no longer able to function reproductively, her drive diminishes to a noticeable extent, whereas that of her partner, her male partner, may not, and usually does not. Using serotonergic agents lowers the libido in all patients who take those medications, but it's not always noticeable. And often, when it's very subtle, because a patient's mind is not on the sex act, they don't notice that they're not having sex as often. But often, if you question and a patient stops and reflects on it and thinks about it, they often can identify that they have been less sexually active than what their norm is, whether or not they are in a relationship and have a partner. The libido is independent of that, and it manifests in different ways, but often men, particularly young men, will deny it any change at all. And then middle-aged men or older men who might also have other health problems, a lot of times won't ever complain of the drive, but will acknowledge some diminishment when the clinician addresses it. And the distinction there is that when a patient, male or female, turns his or her attention to the sex act, if they're then able to muster the emotional response, let alone the physical response that's required, an erection, lubrication, and then they're not going to complain about it, the fact that they're not in the mood as often. Because when they want to have sex, they're able to function reasonably well. And so the complaint that tends to come up is anorgasmia, because sex is not as pleasurable and it doesn't always result in climax on some of these medications.